Good morning. See you again.
We'll go ahead and introduce you. Well, it's my pleasure to welcome everyone here today. I'm Dr. Patrick Cawley. I'm CEO of the health system here at MUSC, and I want to welcome you to the Medical University of South Carolina Healthcare Policy Symposia. We've been running these symposia since 2018. We've been doing them quarterly. Something got in the way in 2020. We moved virtually, and this is the first one in which we are back actually in person. The room's is blunted in terms of size. We didn't allow as many people as live as I think we would have liked, and we have 150 people registered online. So, you know, just think about there's more people listening to you, Dr. Gupta, than you might imagine just by looking in the room. So the purpose of these policy symposia is to, you know, gather the larger South Carolina and MUSC community to converse on important matters of policy, increase awareness of the broader healthcare landscape, and include both state and federal policies in that conversation. Dr. Gupta, who I'll introduce in a second, is our speaker today. We'll have plenty of time for Q&A. For those in the room, it'll be a simple Q&A. At the end, I'll field the questions from online as well. So if you're online and you want to ask a question at any time, you can put a question into the chat and we'll pick it up at the end. So go ahead and please submit your questions. With that, I'd like to introduce Dr. Gupta. Dr. Rahul Gupta is the first medical doctor to serve as the director of the National Drug Policy and lead the Office of National Drug Control Policy, a component of the Executive Office of the President. ONDCP coordinates the nation's $40 billion drug budget and federal policies, including prevention, harm reduction, treatment, recovery support, and supply reduction. Dr. Gupta is a board-certified internist. He's been practicing primary care for more than 25 years, and he served in private practice as well as public health in small towns as well as large cities. He has served as a local public health official, and he is previously the West Virginia State Health Commissioner under two different governors. As West Virginia's Chief Health Officer, he led the opioid crisis response and launched a number of pioneering public health initiatives, including the Neonatal Abstinence Syndrome BioScore program to identify high-risk infants, and for groundbreaking statewide social autopsy, which examined the lives of overdose victims to determine the factors that led to their deaths and what services could have prevented their deaths. He's had a lifelong commitment to educating the next generation of physicians and policymakers, and that has led him to academic appointments currently at Georgetown University School of Medicine, as well as Harvard University School of Public Health. He's got a passion for global health, and this led him to, after his time as the West Virginia Health Commissioner, became the Chief Medical Officer for the March of Dimes, where he served for several years until he moved into his current role. He's the son of an Indian diplomat. He was born in India, but he grew up in the suburbs of Washington, D.C. At 21, he completed medical school at the University of Delhi, followed by subspecialty training in internal medicine and pulmonary medicine. He's got a master's degree in public health from the University of Alabama, Birmingham, and a global master's of business administration from the London School of Economics. He's married to Dr. Seema Verma, a physician in the Veterans Administration for over a decade, and they are the proud parents of identical twins. With that, I'd like to invite Dr. Gupta to the program and look forward to hearing his comments today.
Good morning. Well, first of all, thank you, Dr. Cawley, for those kind words. And thank you to Commissioner Kolosowski and my friend, someone who's passionate about this as much, if not more, than I am. And thanks to the Addiction Crisis Task Force, as well as right here at the Medical University of South Carolina, for having me join you today. Really appreciate that. I'm glad to be in Charleston today and be in South Carolina and speaking to the members of the medical community because our country is at an inflection point. We face a serious challenge. Overdose deaths are hitting new highs, and our national addiction capacity is too low. But we also have the opportunity to create change so that everyone that needs care for substance use disorder can get it. So today I'm going to talk about the state of the overdose epidemic, how the Biden-Harris administration is working to address it, and the role that the medical field, the healthcare systems, play in our collective response to save lives and improve the addiction care across America. But let me start by first talking a little bit about what ONDCP, or the Office of National Drug Control Policy, does and the work we, every day we know. Before he was commissioner, he was Director Kolakowski. So none of this will be new to my friend Gil here. But for all of you who may not have worked with this office before, let me just mention that this office was came into the White House and began operating in 1989. What we do is we develop, implement, and measure the effectiveness of the president's national drug control strategy and oversee the drug-related programs and budgets for about 18 federal agencies across the government that work in this space that span from both public health to national security. What that means is that ONDCP ensures that more than $40 billion in drug control funds get spent on strategies and activities that will reduce drug use and its consequences. Office also works with Congress on potential legislative proposals, and we work closely with communities across the country. So our team includes experts from all things drug policy. So our team has we bring in additional experts from academia, from federal government, and we typically have 6 to 12-month rotations to ensure that our policies are comprehensive and they're well-rounded. So our experts that are in addition to our core team at the office often include those that are coming in from places like CMS, CDC, the United States Public Health Service Corps, the Office of HIV/AIDS Policy. But we also then have experts that come from public safety agencies like the military, DEA, Customs and Border Protection, FBI, and several others. So this allows the extension of the reach of ONDCP and brings partners together to collaborate on the overdose epidemic that otherwise we wouldn't be able to do so. So in short, we develop drug control policy, we bring people together to focus on illicit drug use and its harms, and then we're working really at the intersection of public health and public safety. And I'll explain to you why that's important in a little bit. And the mission to do this has perhaps never been more significant than it is right now today. So let me explain why. You may have seen that the most recent data from the Centers for Disease Control and Prevention that has come out shows that more than 100,000 Americans died of drug overdose in the most recent 12-month period. Think about that. More than 100,000 Americans perished in a 12-month period. This is historic, has never happened before. And nearly 2/3 of these deaths involve synthetic opioids like fentanyl. So what does that mean? That means that nationally, we're losing an American to a drug overdose every 5 minutes. So this mission has never been more important. Let me give you an instance. In South Carolina, there were more than 2,000 deaths in that same period. That means that we're losing more than 5 South Carolinians every single day. It is absolutely staggering, and frankly, it's heartbreaking. These numbers, there are sons and daughters behind these numbers. There are parents and grandparents, there are aunts and uncles. These are real people. You may have come across some of these when you're managing people and you see them no more. I certainly have. And that is what's really unacceptable for us. So that illicit fentanyl that starts as chemical precursors in China ends up in the emergency departments here in Charleston, in Savannah, in Columbia, Greenville, and in so many other communities across this great state. And so much is so true also about across the country. So that we know that the presence of synthetic drugs like fentanyl in our communities is one of the biggest drivers for overdose deaths. We also know that fentanyl can be very powerful in very small amounts, which makes it profitable to criminal organizations and easier to traffic, obviously. Smaller amount, and it's more effective in small amounts, more potent, it's easier to traffic. And that's exactly what makes this crisis so much more deadly today. We're also seeing increases in deaths from stimulants, such as cocaine and psychostimulants, such as meth, which often become contaminated or cut with illicit fentanyl. And compounding this problem is the fact that there aren't enough services that people who are suffering from substance use disorder can access when they want to access and where they want to access. So we have a twofold problem. So the question becomes, how do we address it? So let me talk a little bit about myself. As Dr. Colley mentioned, I've been a primary care physician practicing for about 25 plus years. I've served both rural and urban areas here in the United States and in India. I've served towns as small as 1,900 residents and cities as large as 25 million people plus. I've seen a lot. I've seen TB outbreaks. I've seen overdose outbreaks. I've seen, number of planning exercises for things like Ebola virus disease and H1N1. But when I was an ER physician, when you're in rural towns, you also have to do ER. It doesn't matter whether you were trained or not. That's what you got to do. There were weeks and months where I didn't go a single shift without administering Naloxone or reversing an overdose. When I was a hospitalist, I regularly saw patients that were either admitted to from going through withdrawals, as many of you probably do see, or a number of other consequences of IV drug use, such as endocarditis, such as spinal and brain abscesses, and other skin and soft tissue infections. As a primary care doc, out in the community, anywhere from rural places to hollers to cities, I've treated patients with substance use disorder. I've seen some make it through treatment and get into long-term recovery. And then I've also seen some succumb to their disease. And just like you, I've also had some patients who have gotten arrested from drug manufacturing and dealing. So this is a range that healthcare providers are going to see, and we have to be open to it. So like I said, we face a serious challenge, but we also have within it a unique opportunity to create change like never before by using proven public health strategies to address addiction head on and help build a treatment infrastructure that our country so badly needs today. So the question is, how do we do that? Well, the fact of this is that we are working on it together as local, as state, federal partners, as academia partners, and healthcare institutions. It's a partnership, and we all have a role to play. Let me talk a little bit about what the administration has done. Since day one of his administration, President Biden has been focused on everything we can do to help save lives. A big focus of our strategy is to save lives in two parts. It's providing care for untreated addiction and hitting these transnational criminal organizations where it hurts the most in their pocketbooks. And we're changing how people get the help when it comes to drugs. We're meeting people where they are. We're providing folks services like harm reduction and removing the legal policy and cost barriers to access treatment. The administration announced its first-year drug policy priorities last April, which are based on science, data, and evidence, very clear. These priorities focus on evidence-based prevention, harm reduction, treatment, recovery support services, and of course also paired with reducing the supply of illicit substances into our communities. They also focus on improving racial equity, which is a long-standing problem when we look at drug policy in terms of both healthcare and criminal justice. While President Biden has proposed an unprecedented $41 billion drug control budget, that includes almost a $670 million increases from the previous year's budget to help control this epidemic. We've taken a number of steps already, and I want to share with you a few of the things that we've done as we wait on Congress to act. President Biden signed the American Rescue Plan, or ARPA, some people call it, into law, which invests nearly $4 billion in access to vital mental health and substance use services. We made it easier for healthcare providers to use buprenorphine to treat more patients with opioid use disorders. You may have seen, I myself am a waivered physician, but now up to 30 patients can be treated without having to go through getting the X waiver. That's been very important. And we're working on more. We've also extended the pandemic rule that we're working on right now, changes that allow people with OUD or opioid use disorder, they can get buprenorphine treatment by telehealth, including phone consultation, and patients receiving methadone can now take prescriptions home instead of visiting a clinic every single day. And we work with DEA partners to revise regulations to allow providers to operate mobile methadone vans or mobile meth vans, bringing treatment to rural, incarcerated, and underserved communities. Having worked in West Virginia and some of the other rural communities across the United States, totally understand the importance of how we need to get help to people where they live rather than expect people to come to the brick and mortar systems of care. Because of these actions, we've seen thousands of providers already who have signed up to treat people with addiction in just the last few months. We're constantly monitoring the amounts of signups, and we've seen a real increase in that number. But I'll be realistic, we have so much more work to do. As we get ready to launch President Biden's inaugural drug strategy that is required by Congress later this year, my top priorities I want to list really are focused on helping save lives right now and in the short term as well as the long term. There are four, and I'll go over a little bit of those, okay? First is expanding Naloxone to save lives right away. Second one is expanding access to evidence-based treatment so people can get the help they need, where they need it, when they need it. Third is really improving data collection, having a 21st century data systems to understand better this particular epidemic. And the fourth one is going after the illicit finance mechanisms that drug traffickers use. So we start to reduce the supplies of drugs entering our communities. So let me talk about these a little bit. Let me mention Naloxone. Making naloxone more accessible, affordable, and administrable will definitely save lives. Why do I say that? Well, because I mentioned 2/3 about of the 100,000 deaths are due to the synthetic opioid fentanyl. And obviously it's an opioid. So if we were to have sufficient amounts of naloxone available when people suffer from an overdose, 2/3 of those times will be an opioid, we're going to be able to save tens of thousands of lives potentially. You know as well as I do how often physicians in ER, EMTs, and nurses, and so many others, including people who use drugs and their friends and families, are called on to use naloxone for people oftentimes right after an overdose. I've used naloxone so many times that it's hard to count. The fact of the matter is that most overdoses do not happen in the emergency room. They happen actually out in the community, out in the open. So we have to make sure that naloxone is available out there as well. So our communities need access to these harm reduction strategies, such as naloxone, fentanyl test strips, as well as syringe service programs, which have a proven track record of helping reduce the spread of diseases like HIV and hepatitis, increasing access to healthcare and treatment, and improving certainly the public safety, reducing the cost to society. Having been someone who has practiced harm reduction on the ground, it's very important that everyone who needs access to these life-saving tools is able to get it. In fact, we found that different laws create barriers. Apologies for that. And it creates legal barriers oftentimes. We're concerned that today, where you are often defines when you're suffering from an overdose, and therefore your zip code gets to decide whether you live or die. And that just shouldn't be the case. We should, and the other fact is that these strategies that I'm mentioning have bipartisan support. So it's very important that we create these opportunities for change. Access to these proven life-saving interventions, as I mentioned, should not exclusively depend on where you live. And that's the reason we've partnered with Legislative Analysis and Public Policy Association, or we call it LAPA, to create model state laws on naloxone, on syringe service programs. And we're sharing this information, these tools, with states across the country to make sure that we have more consistent regulations and laws when it comes to saving lives of people. It's really important that we did this with medicine many, many years ago. Whether you're suffering from a heart attack, an MI, in rural towns where I practice, or in Boston, the standard should not vary. You should not be able to say, well, I couldn't get the treatment because I couldn't send them to a cath lab. Well, there's a standard of care expectation there. And we want to do the same thing for people suffering from overdose. We talk about the priority number 2, or treatment. In 2019, only 18% of Americans who needed treatment for illicit drugs received it. 18%, that's less than 1 in 5. There was a time when I could prescribe opioids for chronic pain, but I couldn't prescribe buprenorphine for opioid use disorders. So I had to refer my patients to specialty care. And so what happens in places like West Virginia, that 80-mile difference isn't a 60-minute trip in the hills. It's more like 3 hours of drive, right? Or 2.5 hours of drive. And where people are suffering from substance use disorder, you're talking about gas money, you're talking about childcare, you're talking about taking time away from your job. It just never happens. So it's an important piece I remind us, because right now we are able to treat, thanks to the DEA's revised regulations, up to 30 patients. But then some of you are going to have a challenge. Which 30? So if you have a panel of 2,000 patients, as I did, And you may have people, let's say 100 people who need treatment. And now the question is, which 30 do I decide to treat and which do I not? And that's a challenge that I understand. I see it. And that is why we're making it easier and making every effort possible to make it easier for prescribers to at least treat for opioid use disorder. Make that the easy choice when it comes to writing a prescription for opioids versus writing a prescription for buprenorphine. We need more providers to sign up, but we're continuing to work also to build a system of care that systematically seeks, diagnoses, and treats those who need it rather than waiting until they come into the criminal justice system. Because for too many people, that's what happens. You're either coming into the criminal justice system or you're suffering from an overdose and dying, unfortunately. We also are very committed to reducing the racial inequities related to addiction, especially in healthcare and criminal justice, which often is worse for people of color. The bottom line is that we must reduce barriers to substance use treatment so everyone who needs treatment can access it. So let me talk about data a little bit, because data drives oftentimes equity in access. You know, I recently met Maine Governor Janet Mills, and Governor Mills said to me that overdose deaths in Maine comprise about 7% of all the overdoses in the state of Maine. Well, that means that we have a chance to reach 93 out of every 100 people in Maine who overdose and survive before they experience another and potentially fatal overdose. Just think about that. That's a 14-to-1 ratio approximately. And I suspect that in more places, that's the pattern. And we're trying to learn that. Because when we do not do that, we do not look at an overdose, a non-fatal overdose, as a medical emergency, guess what? People will potentially overdose again, and that may be too late. So imagine how many people in your community today, including your patients, are using illicit substances, including fentanyl. Now imagine reaching them before it's too late. They may want help, but not be able to access it. So let's imagine how we can help them. The last priority is illicit finance, and that's really important because, as I mentioned, there's two drivers, right? The addiction treatment need and access, as well as the profiteering that happens. And we have to attack this key enabler of drug trafficking, the illicit finance network. I went to medical school. Many of you are healthcare professionals, one way or the other. We don't learn enough about this stuff, but it's important to our patients because they're often victimized. So we're going after criminal organizations, big profits, with the new sanction powers that the President recently ordered, as well as law enforcement actions on illicit finance. And just to be clear, they're not the ones that he ordered yesterday. If we prevent or even reduce the amount of these deadly substances in our communities, we will prevent countless overdose deaths. That's the bottom line. We can improve access to naloxone and quality treatment if we can improve our non-fatal overdose collection, like we have seen tracking for non-fatal COVID cases, for example. If we can disrupt drug traffickers, these are the ways we can begin to end this epidemic. As I mentioned, in my experience, every overdose is a cry for help. And we know that for far too many Americans, that cry goes unanswered today. We know that making these changes will help us answer these cries and help us save lives at the end of the day. There's another one of the more pervasive challenges and barriers that we face that I must mention. It's the stigma surrounding substance use disorder. I'd like to read you a passage about another disease from a well-known healthcare organization's history. I'm gonna ask you a question. I'm gonna quiz you what that is, okay? So here we go. Quote, at that time, a diagnosis meant near certain death. Rarely mentioned in public, this disease was steeped in fear and denial. Doctors sometimes did not tell their patients they had it, and patients often did not tell their friends and families that they had been diagnosed with it. Unquote. Any guesses? What disease are we talking about? Yeah, so unfortunately, this organization was Cancer Society, founded in 1913, just before World War I. And of course, it's about cancer. And if I read that corollary, because this is not very dissimilar to the stigma we face around substance use disorder today. You know, our country leaned into this when it came to cancer. We learned more, we advocated for change, and we improved treatments. And today, cancer is a disease that receives more attention, I would say, and funding than just about anything else. Treatment is readily available for so many Americans. There isn't stigma against it like it used to be. When someone you know is diagnosed with cancer, what's your first reaction? It's probably one with compassion, it's one with sadness, but not blaming the victim. It's not about blaming the person for their condition. Even when it's, for example, smoking-related lung cancer, right? We try to fix the lung cancer, not blame the person for it. Yet, unfortunately, that's not the case for addiction today. Stigma often prevents people from getting the help they need. We know that because that's what evidence tells us. And yet we know that evidence-based treatments can save lives. And for much of my career, I worked with patients facing stigma because of their diseases. Whether it was tuberculosis or leprosy that I was treating in India or addiction in the United States. What I've seen is way too many people often aren't able to reveal their disease or feel shunned from society. But society deciding it doesn't like these diseases doesn't make them go away. People with diseases are still people, and they are still deserving of our compassion and evidence-based treatment. So the role of medical community is exactly that, and that's where you come in. You can screen your patients for SUD and become waiver to treat up to or more than 30 patients now with you. You can carry Naloxone with you. You can co-prescribe Naloxone to those who are being prescribed opioids. You can advocate for change, including establishing and expanding harm reduction tools like Naloxone, fentanyl test strips, and syringe service programs, which we know are known to save lives, prevent overdose, as well as reduce the spread of diseases like HIV and hepatitis C. And in doing so, you're breaking the stigma, basically. So what this boils down to for me is that every life is valuable and worthy of saving. And you have a major role to play in this response. I know that working together, we can prevent overdoses, we can save lives, but we can also treat people and prevent these expensive lifelong diseases, communicable diseases. And at the end, we can also break the stigma that prevents people from getting the help that they need. We can also prevent families, more families, from saying goodbye to loved ones too soon. So yes, we face a serious challenge, there's no doubt about it. But as I've said, we also have a unique opportunity to create a change that our countries and our communities desperately need at a time when the overdose deaths are an all-time historic high. I'm going to be working tirelessly for this change. It's my 4th month in the office, and I hope that I can count on you to do the same. You know, I will say this, President Biden recently said when it comes to saving lives, we won't let up. That was exactly his words. So thank you for your dedication to addressing this disease, as well as the stigma that goes along with it. And we will not let up as a community, as a country, and as a state here. Thank you so much.
Why don't you come out here? And we got, let's start with some questions in the room first, and we already got a few questions online. I'll start those when we finish up with the room. But thank you for that talk. Very enlightening. There's a lot to unpack there in this tough public health problem. So let's start right here.
Or, you know, it's a very pervasive thing, and we really, you know, the evidence base around, we can come up with case studies like cancer where we know that somehow it was diminished over time, but the evidence base around interventions that as a society that we can take is pretty slim. So I'm wondering what your thoughts are beyond the healthcare professionals in terms of addressing the stigma.
Dr. Gupta, let me just repeat it so people online can hear. So Dr. Brady asked a question about stigma and what possible interventions can be addressed to deal with that issue.
Yeah, so thank you for that question. Clearly, there's a role to play here for the healthcare community. But one of the things I've always been impressed, and that's what led me to public health focus from pure internal medicine practice, is the fact that when someone comes to us for the 3rd time this week with an overdose or with meth use or what have you, it's addiction, but it's also the societal factors. What are the other factors, right? So what we see in emergency rooms often is the tip of the iceberg. So it's very important for us to look at those, we call the social determinants of health, or the other aspects of people's lives. And I think we have a role to play in that as healthcare providers to understand better. I think the days of the 4 walls of the brick and mortar clinic or a hospital, and that's only the place that we're going to take care of people, is over. We have to look at the underlying factors, whether there's homelessness, poverty, racism, food insecurity, transportation, daycare. All of these things and many more have an intricate role that plays in that one person's life that leads to this place. So I'll say from this aspect, when we're talking about infrastructure money, or we're talking about a number of other things in Washington, I think about those things. I think about the underlying factors that often create hopelessness for individuals that could and may lead to addiction. So, but it's also important for us as providers and as leaders in communities to also be thinking that way.
Thank you.
I've been really excited with the new pharmacy that Mark Cuban has come out with recently. That's basically underselling the drugs. But has there been any thought of partnership or working together with that or a similar entity to make naloxone or buprenorphine more accessible?
The question from the room is regarding ways to make naloxone more accessible, financially, that is.
Thank you for that question. Very important question. When we talk about expanding treatment, having treatment infrastructure, both from naloxone as well as from other medications, it is something that from a policy perspective we look at. We look at everything from manufacturing, supply chain, to the ability. Now, we hear often from pharmacies or from stakeholders about pharmacies that are often not carrying when it comes to naloxone or buprenorphine or others, and that becomes a concern to us. So the entire supply chain is important, and you're right. We saw that with COVID vaccine, right? So whether it's the Band-Aid or it's the, you name it, the alcohol swabs, they all have a relevance, and we need to make sure that's happening. So we're certainly keeping a pulse on that. Thank you for that question.
Follow up on the Narcan topic just for a moment. I was on a call one day where someone from the FDA was on the call, and the topic of over-the-counter Narcan came up, and they suggested that they would be amenable to that possibility if it was so requested. Do you think that making it over-the-counter would help?
The question in the room is about over-the-counter availability of naloxone.
Yeah, so that is, I mean, look, from a perspective of, we're looking at 65,000 Americans dying, predominantly with the lack of availability to naloxone, right? So we have to make every effort. But we also have to make sure that, what are the challenges? The challenge is accessibility, affordability, and administrability. Those are the 3 A's. So people can't access it, oftentimes because of regulations, policies, or jurisdictional issues. They can't afford it because, you know, there's a lot of drugs today that are available over the counter, but people can't afford those. So if we think about that, and then administrability, want to make sure that everyone who is needing a naloxone gets it when they need it, where they are. So if you keep those like 3 sort of as the guideline for us, I think it helps us take every effort possible to make that accessible, but we want to make sure that it gets into people's arms or nose or however it's administered at the end of the day. So that's the important piece of this is.
One of the questions from online referenced telehealth. You mentioned telehealth as an important element of dealing with this crisis. Many of the current telehealth policies are reliant on the public health emergency. And your thoughts on what's going to happen once the public health emergency is over, and how we're going to use telehealth to combat this issue?
Yes, there have been obviously so many unfortunate deaths and consequences of the pandemic. One of the silver linings is that we've probably pushed our ability fast forwarded for telehealth by many years. And we certainly are looking at this and attempting to preserve the positive aspects of the pandemic policies, some of which include telehealth. So we're looking forward to leaning in to some of these telehealth policies that allow us to save more lives, provide expanded treatment, especially in rural communities, and partner with you know, large academic environment and organizations like the one right here.
Questions in the room? Dr. Darby?
Yeah, you mentioned a little bit about one of the things you would go after would be the drug criminal control of the distribution industry, which might be one of the biggest industries in the country. And I've been around a long time. Each year, it seems to get bigger and better from their standpoint. And I wondered if the Biden administration has any innovative way of going after that, or we're just going to continue to do what we have done in the past, which seems to be a failure.
The question in the room is regarding innovative methods to deal with the criminal elements of distribution of these illicit drugs.
Thank you for that question. Yes, the answer is that we've seen how today this fentanyl is coming from outside of the United States into the United States. That's also true for other substances as well. So one of the things we're doing is we're taking a public health approach so many ways when we're working with other countries, partner nations such as Mexico, Colombia. We're really excited about some of the work that is going to be happening. The president has signed with President Obrador a bicentennial framework with Mexico that allows us to look at both the public health and public safety aspects. I was in Mexico back in November, and for the first time in our relationship, they mentioned that there's a demand problem in Mexico. Traditionally, the relationship did not factor that in. So now we're working as partners, as true partners, to figure out how to help both the Mexican authorities, but also hold them accountable at the same time. Same way with Colombia. We're looking at, as opposed to a transactional relationship of how much cocoa fields you can just eradicate and tell us, and that's it. We're looking at a relationship that combines eradication with rural development and safety and environmental protection. And those things are important because some of the environmental impact, as an example, on that happens as a consequence of growing cocoa and using those chemicals are damaging, and they're tough. And these farmers have lived with their land for thousands of years, and now this damage is happening. So we want to account for environmental protection. We want to figure out how to help substitution for the economy that is of cocoa with rural development and rural security, and at the same time, pressure on eradication. So it's true partnership as opposed to transactional partnership that we're trying to develop. So these are examples of public health models and approach that we're taking to bring nations, partner nations, into a framework of true partnership, framework development from a public health standpoint, and ultimately hope that these initiatives are more sustainable and long lasting.
Let me take one or two more questions.
Good morning. This question's a caveat. I'm actually the Charleston County coroner and the current president of the International Association of Coroners and Medical Examiners. My question is, as we look at the stats that are off the charts, as you said, I believe those numbers are low. And the reason is due to a shortage of forensic pathologists around the country and the lack of resources down at the coroner and medical examiner level. So my question from a public health standpoint, we play a public health role in making sure our statistics are accurate. That is there a support coming down from the administration to be able to support at the local level, coroners, medical examiners, and forensic pathologists to make sure that our statistics are correct? Because if they're as high as we probably believe they are, I think the world would be even more overwhelmed by the numbers.
The question in the room comes from our local coroner here in Charleston, who's questioning the numbers, mainly due to issues with trained personnel to make sure that the cause of death is correct.
Thank you for that question. As Commissioner of West Virginia is one of those states that has centralized medical examiner's office that reports up to the commissioner. So I'm very intricately familiar with both the workforce issues, the shortage relatively of the forensic pathologists across the country, and the sort of stiff competition for that each year, as well as I suspect that you're correct that these predictions are underestimates of real numbers. So there is work that our partners at CDC are doing with coroners to get better quality data, and that work is ongoing. We would love to share that with you so you're aware of that. But that is another area of workforce that I have seen close and personal, how difficult, because we don't often think about when we have rises in overdose deaths. The budgets of often the coroner's office do not change, if anything, and that's an additional burden. So I appreciate the question. I do think that we're doing some work with our partners at CDC, with the medical examiner's office, and we'll be happy to share that with you.
One more question from the room.
I was wondering about the approach of kind of targeting the supply chain and the data driving that as a viable approach. As far as, does it reduce overdose deaths, or could it actually, as Dr. Darby kind of alluded to, fuel innovation, shift towards more potent, deadly opioids, and just kind of what data is driving that approach?
The question is about what's the data behind disrupting supply, exactly what happens.
I think that's a really good question, one that we are constantly discussing and debating, which is obviously when we saw Chinese put in new regulations to prohibit fentanyl production and shipping in China in 2019, we have almost seen almost zero shipments of fentanyl from China. But then what's happened is the precursors are being shipped from China. And they are coming in from various places, ultimately ending up oftentimes in Mexico. They're going to these synthetic labs in Mexico, and then that gets trafficked. So it's always a challenge of how do you address the supply chain, and we're working with the People's Republic of China right now to say, well, we need to make sure that some of these chemical shipments that are happening are better monitored, more homogenized to international shipping systems and all of that. But the fact of the matter is there will be always licit elements conducting illicit work and illicit elements for profit. What one common theme is all of this in it is the profit-making effort. And that's one of the reasons when we look at the supply side, you see one of my 4 priorities is illicit finance. It's not supply reduction, it's not supply chain, it's actually going after the money. Because one of the things we know is, for example, I was down in Miami last week, and off the we were unloading about $1 billion worth of drugs off the Cutter James Coast Guard. Now, what we do know is that's the amount of drugs that are not in your community right now. They're not killing people in your community right now. We also know those are the profits that have been denied to the drug traffickers so that they could go and spread crime, violence, and corruption in host nations, which often cause destabilization in fragile democracies. Is that enough? Probably not. Is it important? Probably is. So that's the challenge we're constantly facing, disrupting the supply, because when we disrupt supply, it allows us space for our demand efforts to take root. Because while we are expanding treatment, making a paradigm shift in harm reduction, evidence-based prevention, we do need space for those efforts to take root. For that, we need to have breathing room. And we believe that it has to be, the work has to be at the intersection of public health and public safety for that very reason.
Great, thank you. I want to thank everybody for coming today. I really want to thank Dr. Gupta. I want to thank him for a great talk on a subject that I know has affected many people in this room personally. It's hard to find somebody that's not been affected personally by this problem, and thank you for helping shine a light on it and not stopping. We had some discussion last night, and he's got a deep passion for this, and I appreciate that. I also want to thank him for his public service, and especially thanking him for coming today and helping to continue this conversation here in Charleston. We got a great conversation going on in Charleston. It's rippling across the state, and then we have many state officials here today who are helping to get this word out as well. So once again, thank you for coming and appreciate your time and attention.
Thank you, Dr. Colley. Thank you.
Appreciate it. Yeah, just leave it.